Hello, and welcome to the third webinar of NASTAD's Hepatitis Testing Partnership titled The Role of Community-Based Testing in Hepatitis Elimination. My name is Alyssa Kitlis, and I'm a manager in NASTAD's Hepatitis program, and I am the main point of contact for this group. For those of you who are unfamiliar with the Hepatitis Testing Partnership, NASTAD convenes this coalition of stakeholders, including public health, community-based organizations, academic partners, and really anyone who's engaged or should be engaged in hepatitis testing. And my goal for this group is really to include anyone who wants to test for hepatitis. And that includes federally qualified health centers, substance use treatment facilities, and even more unconventional partners such as faith communities. So if you know anyone who wants to test or should be testing and could benefit from being part of this group, please let me know. And this group convenes via a listserv and through these quarterly webinars to share best practices, lessons learned, and resources related to testing. And some of the topics that have been suggested for future webinars include public health detailing as a strategy to increase testing, testing in correctional settings, lessons learned from HIV programs, linkage to care, and testing pregnant women and children. So we have a lot of exciting opportunities for webinars next year. But I do really want this group to be responsive and as helpful as possible. So if there's something that you want to learn more about or that you want to present on from your work, please always feel free to let me know. So before we get started on today's call, I'm going to walk through a few housekeeping items. First, this webinar is being recorded, and all the slides and the recording will be available on the Hepatitis Testing Partnership page. And I'll share the link to that page in the chat box momentarily. And also, we're going to be muting all the lines during the presentations, and we are going to hold most of the questions until the end. But if there's any clarifying questions that you have, or if during any part of the presentation something comes up from your work that you want to share, please feel free to reach out and include that in the chat box. We'll both have a discussion on the phone, but also a chat in the chat box. So there will be lots of opportunity to hear more about the work you're doing and for you to share your experiences and lessons learned as well. So as I mentioned, today's call will focus on the role of community-based testing and hepatitis elimination. And what we mean by that is really any testing that takes place outside of primary care and in community settings. So community testing events, health fairs, testing that takes place at syringe service sites, substance use treatment facilities, homeless shelters, methadone maintenance programs, in churches, and testing that often takes place by organizations that specifically serve people who are most impacted by hepatitis. And the goal of community-based testing is really to make sure people have access who might not primarily have access through other healthcare settings like primary care. So today we're joined by two wonderful speakers who will share about their organization and the work they're doing to increase community-based testing and some of the lessons they've learned. But before I turn it over to them, I just wanted to provide a brief overview of the global conversation around hepatitis elimination so we can start to think about how community-based testing fits into that conversation. So as many of you know, in 2016, the World Health Organization released the Global Health Sector Strategy on Viral Hepatitis for 2016 through 2021. And this strategy outlines a number of priority areas and targets for elimination. And you can see the continuum that they included here on the screen. And that really includes everything from testing to linkage and retention and care. And one of the priority areas is around testing, and that the baseline started in 2015, that less than 5% of people around the globe who have chronic viral hepatitis have been diagnosed and are aware of their status. And the goal in the elimination strategy is to get it to about 90% in 2030. So the World Health Organization has outlined some pretty ambitious targets, but to date, over 80 countries have developed their own plans for elimination, and 9 countries are actually on track to eliminate hepatitis B and C by 2030. So one thing to note, and I'm sure many of you are aware, that the conversation really is around elimination rather than eradication, because there's just too high of a prevalence to actually eradicate viral hepatitis. And really the goal is around reducing new infections and making sure everyone who's living with hepatitis is treated to reduce mortality. So here in the United States, the National Academies of Sciences, Engineering, and Medicine convened a commission to first determine whether or not elimination was feasible, and if it was determined to be feasible, to outline some targets and recommendations for getting there. So earlier this year, the commission released the phase 2 report that highlighted some targets and recommendations for elimination. And the overall message from this report is that elimination in the US is feasible, but we would need significant resources and political will to get there. And also we would really need to make addressing hepatitis more of a priority. So a number of recommendations were included in terms of how we could get there and make hepatitis more of a priority. And most of them do focus on treatment and access to care and those bars further down the continuum. But there was one specifically focused on testing, and it calls out the need to enhance testing in strategic settings. And the report highlights that the people who are suffering from or are most at risk for hepatitis B and C are not engaged in care, and so we need to do something to reach these people. And community-based testing is an important way to do that. And so just wanted to highlight, I think most of you know, but where we are in terms of getting towards these elimination goals. So we don't currently have a care continuum for hepatitis B, but only about 1/3 of people living with hepatitis B in the United States are aware of their status. And this is an outdated cure cascade for hepatitis C, and I'm hoping it's increased significantly now that we have new direct-acting antiretrovirals. But one thing to note about this is that only about 50% of people in the United States who are living with hepatitis C have been diagnosed and are aware of their status. And we know that this is likely a gross underestimate. And this is just really important because in order to reach those further goals of getting people into treatment, we really need to make sure they're aware of their status. And we all know that the asymptomatic nature of hepatitis B and C makes testing even more important. So testing in general is a critical piece of the elimination puzzle, but we really need to make sure we're getting out of primary care settings and getting into the community to make sure people who are most impacted by hepatitis have access to testing and then further linkage to care. So community-based testing also plays an important role in eliminating disparities. I included some of the disparities that exist related to hepatitis B and C, and this is primarily just in terms of infection, but people of Asian American and Pacific Islander descent only make up 5% of the US population, but account for over 50% of people living with hepatitis B, and Black Americans make up approximately 11% of US population, but account for 25% of people living with HCV. So there are a number of disparities that exist both in people who are infected, but also health outcomes, and getting into community settings and making sure that people who don't have access to primary care, either because of insurance status, immigration status, or other barriers, have access to testing. And also community-based testing plays an important role in addressing stigma. And we'll hear some good examples of how community-based organizations are working to provide culturally and linguistically competent services. So that's a very broad overview in terms of where we see community-based testing fitting into the overall elimination of hepatitis B and C globally and specifically within the US. But I wanted to provide that just to kind of lay the groundwork for the conversations we're going to hear today. And I think one thing also to note is just the opportunity that exists with community-based testing. I included a couple graphs from a NASTAD report on HIV testing and billing. And the one on the left shows that about 58% of settings that offer HIV testing, primarily that are funded by health departments, are offering hepatitis testing in select venues. and only about 17% are offering them in both. And so I think we have a lot of infrastructure in places where within the community HIV programs are testing that aren't yet testing for hepatitis B, and this provides a really important opportunity as we expand testing and work towards elimination. So I'm going to now turn it over to two great speakers today to share examples and lessons learned from their organization and put a little bit more of that broader context into a direct forum to share about the work that they're doing. So first, we're going to hear from Christine Thomas from the Hepatitis B Initiative DC. And Christine recently joined HBI DC to assist with monitoring and evaluation efforts and to increase outreach activities within the DC area following an internship at the World Health Organization. And then we will hear from Carlene McGuffey from Climbing for Carlene. And Carlene really travels all over the US to make sure people are tested and linked to care for hepatitis C. So I'm excited that we have both of these examples. And as I mentioned, following those presentations, I'm hoping to have about 20 minutes for discussion and Q&A, because I know there are a number of people on the call who are doing a lot of testing and have a lot of experience in this area, and would love to hear what's working for you and how you see testing, particularly in community-based settings, fitting into elimination more broadly. So I'm going to turn it over to Christine to get us started.
Thanks so much, Alyssa. Hello, everyone. I'm so excited to talk with you today about the Hepatitis B Initiative of Washington, D.C. So we'll just get started with the presentation. Next slide, please. Thank you. And talking about our why. And so I know that Alyssa was so kind in discussing the issues surrounding hepatitis C. For HBI DC, we do have a heavy focus on hepatitis B. And so we do know that there are 700,000 to 1.4 million people who are estimated to have chronic hepatitis B. 240 million people globally are infected by chronic hepatitis B, and there are 786,000 deaths by chronic hepatitis B each year. Next slide. So our organization has the vision to see a world free from liver diseases caused by viral hepatitis. And this is done by envisioning a world free of liver disease, again, caused by viral hepatitis, doing this by educating, empowering, and eradicating. And so education is for the at-risk and underserved communities. Empowerment is to for the impacted communities by partnering with civic, nonprofit, governmental, and faith-based organizations, and the eradication of viral hepatitis by providing screenings, vaccinations for hepatitis B, and referrals to treatment. So I do want to ask everyone, you know, who here as a part of the attendees is providing screening services to more than one ethnic community? I know I had a poll set up. I'm not sure if it's able to do, but I'd love to see if you guys could drop a yes or no maybe in the chat box, just so I can see where you guys are on the spectrum of community engaged screening. Okay. Okay, great. So yeah, I see. There we go. So we do have a lot of people who are engaging with more than one ethnic group. We do have some that are just one ethnic group. And so I just wanted to kind of see where some people were in that. So next slide, please. HBIDC is focused on more than one ethnic group as well. Our organization's mission is to mobilize communities to prevent liver diseases caused by viral hepatitis among Asian Americans and Pacific Islanders, African immigrants, and other high-risk groups. This is done through collaborative partnerships, and our organization provides culturally and linguistically appropriate viral hepatitis outreach, education, screening, Hep B vaccination, linkage to care, and patient navigation services for impacted communities. Next slide. So when we talk about the services, it really is from our mission statement. We really want to go from having those collaborative partnerships through the outreach education, through the health screening, the vaccinations, and finally the linkage to care and patient navigator services. So we have, starting off with collaborative partnerships, let's just talk a little bit more about what that looks like for us. Next slide. So our partnerships are with various stakeholders. We engage with the departments of health within the area. Our organization engages with the Department of Health for Washington, D.C., Maryland, and Virginia, as we service all three of those areas. We have a strong engagement with faith-based organizations, as we found that they're really important to ensuring that the at-risk communities that we're targeting are able to have that linkage, and we're able to really reach them in a culturally appropriate setting. Health clinics have been a part of our team. Community businesses such as restaurants, hair salons, those braiding salons, nail salons, markets, anything that is a part of the fabric of a community. We really want to engage with them. Physicians, we definitely look to them to provide that linkage to care as we look for African physicians, Asian American physicians, et cetera, that are able to provide the culturally and linguistically appropriate care to the individuals and community leaders. Next slide. So in talking, again, moving from collaborative partnerships, we see that now it's about outreach education. So we have two types of outreach. Those are generally venue-based and we have street-based. And venue-based is what we do when we're going to a faith-based organization, when we're going to dealing with clinics. They are able to provide us with the leadership and engagement with the community. So in the instance of a faith-based organization, whether it's the pastor, whether it's the leader of the organization, they're able to provide ownership as well as link us to people in the congregation, sharing our information so that people can understand what it is that we're doing, and they assist us in helping with reducing stigma as well. Street-based outreach is when we do canvas door-to-door, business-to-business, to increase the education for those individuals who may not have time to go to the screening events that we have that are venue-based, or they don't really see our information around. We go to them and we ensure that they're able to hear directly from us what it is that we can provide and how we can address some of the hepatitis issues within their community. Within the health screening, that is where we have our main events. That's where we have the health screening events in the community. And from there, we then link to the hepatitis B vaccinations. And beyond that, we do linkages to care and patient navigator services. This is things like vaccinations and treatment. And again, the language and cultural appropriate navigation through these services. So this can be through, for example, the NIH, which has some of the best in the area, some of the best research has been done for hepatitis B. Certain universities have partnered with us. So these are just examples of ways that we're able to link to care, specifically since hepatitis B does not have a cure and there will be ongoing treatment. Next slide. So if we were to talk about our how-to for health screening events, we have identified 5 major steps in how we are able to make health screening events possible. The first is through securing funding. It is so important for us, as we are a nonprofit organization, to have the funding. This is through corporations, departments of health, foundations, state grants, and our own fundraising efforts, that we're able to get the resources that we can then move forward in providing the services. We then identify the target population. So we identify within Asian Americans, we may say that this is time that we are going to engage with the Mongolian community or the Chinese community, etc. So we identify our target population, and then we identify the best methods to reach the community. Is it a faith-based organization? Is it more street-based outreach? Is it that we need to utilize the community leaders more and have them go by word of mouth? Finally, we have the venue and street-based outreach. And then from there, we have our health screening event. And we've been so grateful that oftentimes, if available, the departments of health for this area have been able to provide the vaccines for the hepatitis B to the clients that we're engaging with. Next slide. So in looking now at this year for DC, Maryland, and Virginia, we have been able to do a lot with us such a small organization. We have educated almost 5,000 individuals. Over 2,500 have been screened for Hep B, almost 2,400 for Hep C, and about 60 screened for HIV. We have had 52 total events and been able to identify those positive with hepatitis B and hepatitis C. Next slide. So out of the total patient screened, we see that the vast majority of our community, our patients, I should say, are Asian and Pacific Islanders. We have been targeting now within the very recent past, looking to engage even further with African immigrants. So we've been looking to engage with the community leaders, with the faith-based organizations. And then there are some other communities that are present in the screenings because it is such an open event. Out of all of these individuals screened, we have been able to target a total of 65 unique communities. And some of these include those from Burma, Mongolia, Ghana, Sierra Leone, Korea, China, Cambodia, Cameroon, Ethiopia, and Nigeria. And our goal as an organization is that every single year we are trying to target a new community group. Even if they are from the same country, we have noticed that they do have different community groups, such as those from Ethiopia do have different tribes. So we really are looking to just continue our outreach efforts every single year. Next slide. So some of the lessons we've learned, some of the challenges we've seen are the knowledge. There's a lot of individuals who do not know what hepatitis B and C would look like for them, what it looks like for your longevity and your quality of life. And so we see that a lot of this has been related to stigma. Communities may not think that this is something that's positive and they really don't want to know information. So we found that in order to combat this, our successes have been seen in our engagement with the community. Because we engage thoroughly with the fabric of the community, we've been able to see that there's been increased education of individuals. We provide education in culturally and linguistically appropriate materials, and we've been very persistent and present within the community. A lot of times we've noticed that communities have seen organizations or groups come and go, and so there's not really a buy-in by the community. And so that has been very important to us, to ensure that they own this, that they really want to participate in this, because this is the only way that we can really assist the community. Next slide. So we've seen that then it allows us to provide the linkage to care. Next slide. So overall, for our organization, we have seen that since our inception as a nonprofit organization, we have been able to educate over 22,000 people, screen over 14,000 for hepatitis B, and identify those who are positive and link them to appropriate care. We have been able to screen almost 8,000 people for hepatitis C, and also, again, screen and link them to appropriate care. Next slide. So an example of just how much we love the communities we work with, we were able to have a 10th anniversary celebration last year that was just able to have all of the physicians who provide the culturally and linguistically appropriate services, a lot of the community leaders, different stakeholders, whether it's departments of health or businesses, they were able to come and we were able to honor them and thank them because for 10 years, we were able to provide direct services to the community. Next slide. Then as well, yesterday, which is last year was such a fabulous year for us, we were able to have our program have national recognition for the 2016 Viral Hepatitis Testing Award from the U.S. Department of Health and Human Services. So we just were able to do so much through the support of our stakeholders, through the support of the community. And that's it for my presentation. Thank you so much.
Thank you so much, Christine. And I'll turn it over to Carlene, and then, like I mentioned, we'll hold questions until the end. So it's all yours, Carlene. And Carlene, just make sure your line isn't muted because we can't hear you. Okay, just 1 second. I feel like we might have lost Carlene, so I'm just going to see if we can find her. She was dialed in earlier, and so want to make sure she's able to share about the work she's doing through her organization. And while we look for Carlene, did anyone have any questions for Christine? We can include some now while we're trying to figure out the technical difficulties. And feel free to include your questions in the chat box. Christine, I do have a question for you just to kind of make sure we can find Carlene. How do you mentioned the importance of linking folks to care, and I know one of the big things that HBIDC does is reflex confirmatory testing for hepatitis C, which is a really important part of making sure people are actually diagnosed for hepatitis C. Do you have any advice about how to assure confirmatory testing and linkage to care in a community setting? Because I know that can be a challenge for many organizations.
So after the Hep C testing, so at our screening events, we do provide rapid testing for Hep C, but following that, we do screen additionally in the laboratory for the RNA of the Hep C. So we're able to see the viral load for those individuals who return positive with Hep C. From that information, we're able to see what type of care they should be linked to. Yeah, does that answer your question?
Yeah, that's really helpful. Thanks. And that was perfect.
I see this other question.
Oh, great. Yeah, sure. If you want to answer this from Catherine, she's wondering if you could provide any advice on gaining access and buy-in within the African immigrant community or communities broadly.
Yeah. I definitely do know that the African immigrant community is a very, very tight-knit community. And so we have found that for us, our success has been when we've had a community leader assist us in creating an opening so that we can communicate with them. So, for example, we were able to engage with some physicians who said, yes, we would love to provide culturally and linguistically appropriate care to those who return positive for hepatitis C or B or need vaccinations. So from this, they were able to assist us in targeting additional faith-based organizations or businesses or communities. And so then we were able to provide the education that led to them having trust with us and just being persistent and present with the community. That's just really key, persistence and presence. And then from there, we're able to work towards having a screening event. Oh, for the RNA testing, I'm sorry, I don't want to pause. I didn't want to take over for Carlene.
Yeah, Christine, let's hold the additional RNA question to the end, because I think that's an important question. But it sounds like Carlene's sound is working. I heard her say hello. So we'll turn it over to her to hear a little bit about her organization and the testing events they hold, and then I will make a note to go to that question when we start the Q&A at the end. So thank you for that. And Carlene, I'm going to turn it over to you for real this time. Hopefully we don't have any problems hearing you. Carlene, it says your line's unmuted. Do you mind trying to talk again? For some reason, there's something strange going on with your sound.
This is Chris with NASTAD. Why don't, while we're working on getting Carlene connected, if Christine, if you want to maybe answer that question about RNA testing. It was how do you work to get clients to come back for RNA testing that is often a challenge, or do they do RNA testing the same day?
Yeah, no problem. So yes, we do RNA testing the same day because we're drawing blood for the hepatitis B. We are doing a rapid test for hepatitis C. If we see that the rapid test comes back positive, we just add an additional check mark on our lab slip to let the lab know we do want additional testing for the RNA. So it's really a smooth process, so that way we don't have to worry about losing anybody.
Great, thank you.
Thanks, Chris. And Carlene, are you able to hear us? I'm wondering if you want to try connecting via your computer. I know that was working earlier before you called in. And while you're working on that, we can always ask Christine another question. So, Christine, I know there are a lot of benefits to community-based testing, and we talked about some of the challenges, such as people not coming back for RNA tests. I know Melissa shared that from her experience, but what do you see being like some of the challenges that you face, and do you have any ideas or any insight in successful ways of overcoming those challenges? I mean, you spoke to this a little bit before, but any other lessons learned you want to expand upon?
Yeah, I would say one of the biggest things is patience. It's with communities that are, especially immigrant communities, since those are ones that we're targeting, there really has to be trust built, and it really has to come in a way that's respectful to them. So we can see that if we're trying to engage, and no matter how great our efforts are, if we are not approaching these individuals and these communities in a more patient manner, in a way that lets them express themselves, doing research on whether there's stigma in the community, because not all Asian immigrant communities do have stigma. So that allows us to know kind of how to address things. For example, we've noticed in some of our communities that because of the stigma associated with hepatitis screening, we provide glucose and cholesterol screening. So that way individuals feel more comfortable. Oh, I think she's
great.
Back. I'll stop.
Yeah, she's back. Thank you.
Forgive me. I X'd out of my computer and called in on my phone. I don't know what happened. I was furiously muting and unmuting and trying, and I know we were corresponding in the chat box forgive me. Let's do this. You all ready? You can hear me?
Yeah, we can hear you now,
me.
Carlene. And thank you so much,
so,
Christine, for answering those questions in between. And then if there's anything else you want to share, I think the pieces you were highlighting were really important, and we can just segue back to that in the Q&A section. So, sorry.
Next slide, how it began, Alyssa. Next slide. So I'll just share that whenever I was a teenager, you can hear me, Alyssa, right?
Yep, sounds great.
Okay, great. Whenever I was a teenager, I was an IV drug user, and I also lost a baby when I was 16 years old, which was about 1988. So I had a blood transfusion. I was living on the streets of Houston, really, Lower Westheimer. And so it was right before they started checking our blood supply. So I can't pin down just exactly when I contracted the virus, but I've mainly shared over the years that I had a blood transfusion because of the stigma. And I had committed not to share my past with anyone unless I felt like it could be helpful. So I've just recently really shared a lot about my past because I do feel like it can be helpful. I changed my life radically and didn't think about hepatitis C for about 25 years. I'm pretty typical in that I had the disease for decades before I was diagnosed. I actually had pain on my left side, which is opposite the liver, but it was an enlarged spleen due to my liver. And the doctor that I saw was notorious for just checking every box on the lab slip. The ladies in the lab called her a vampire. But fortunately, she had checked the box for hepatitis C and called me and told me that I had hep C. So I was really fortunate to have found out whenever I did, because I had these other symptoms, and it's really typical, and I know everyone knows this. Hepatitis C is a systemic illness. For it to manifest in other areas, and for a doctor just to assume that we need to eat better, exercise more, or the diabetes that we have is because of diet or genetics, and they don't assume hepatitis C. And so I was really fortunate. Next slide. And Alyssa, I'm not on my computer anymore, and so I can't see the slides. I'm just going to assume that we're on the same page. This is slide 3. So I had a biopsy about 6 years ago after my last baby was born. He was 8 weeks old, and the doctor cut an artery in my liver. And it was during that time that, I had to wean my baby overnight. We tried to keep him in ICU with us for a couple of nights, and it was really impossible. And it was very hard and devastating and traumatic for me. I'd nursed all of my babies until I was embarrassed or they could ask for it. And so it meant a lot for me to be able to nurture and nurse my children and take care of them. And here I was, laid up completely incapacitated in the hospital for a month and then in bed for a year. So this is really what prompted my husband to start our organization, just the lack of resources and the issues that I had in my own personal life, the complications due to hepatitis C. Next slide. So if you can see that picture of my liver there on the left, there's some lines on it showing I had a 13-centimeter hematoma on my liver, and it took over a year to absorb, and I still have permanent nerve damage in my liver area because of this severed artery. But it was during that time that my husband said, you know what, this is ridiculous. There are no resources. There is no good information. And we kept getting misinformation or bad information from even providers. And I don't begrudge any of our providers. I know there's not a lot of incentive to go into Hep C. It's not very lucrative or glamorous. And so, and it was a lot of really poor patients, perhaps on Medicaid, and yet high side effects with interferon. And so it just wasn't a good return on physicians' investment to recruit those kinds of patients. And so we had a really hard time. And my husband got frustrated, contacted the American Liver Foundation, and started a foundation, started climbing mountains to raise awareness for hepatitis C on my behalf, and that's why it's called Climbing for Carlene. Of what we do, we've narrowed it down. We've had to, I think everybody's passionate about hitting this disease at every angle, but stigma, medicine, organ donation, testing, education, and veterans are our main objectives. And of those, we feel like testing may indeed be the most important, and that is just simply because 75% of people with Hep C don't know their status, and it's so important for people to understand their status early so that they can treat early. And it just makes sense economically. It makes sense in the community. I know when I found out, I put my razor up, I put my toothbrush up, and I know that people are more inclined to not share needles or to do the same thing that I did, just be more cautious. It's better, even if a client doesn't immediately go and get cured, knowing our status early is extremely important, in my opinion. And so that's really what our heart is just to screen clients. We don't really test. We screen them for the antibody, and of course they have to get a confirmatory. But I don't know who's heard this, but just yesterday there was a report that came out that said that people that know their status these are users in a rehab, are 33% more likely to significantly reduce their drug use. And I think this is confirming a lot of our assumptions that whenever we love people and we care for them and we generously serve them with testing and screening and medicine and resources and counsel, it can be the very catalyst or the push that they need to promote them to behave better. And so this report is really exciting to me. These are people that were in a rehab. They're 33% more inclined when they have a diagnosis to stop using drugs. I know it's for a variety of reasons. They're scared. But I think that they, perhaps it shares with them the fragility of life, and then they get this expensive medicine. And I think that's one of the really important reasons that we shouldn't ration medicine, even if someone's stage 1 or 2, to say to someone here, you're worthy of a test, and you're also worthy of follow-up and a linkage to care in these labs and this gastroenterologist, and then a medicine and the cure. It speaks to someone to say that, even if they are a user, to say you're worthy of our time and our expensive medicine and our very best effort. And I think that doing so is more than just giving someone a pill. I think it gives them self-worth. And even if they're at that time not, they're behaving poorly or engaging in very risky behaviors, and they don't have much worth to, their family or the world around them, to put that on them, it can sometimes grow that person into the way that we are treating them. So we treat them well and they begin to behave well. That's, I think, really important. So we got our CLIA waiver and we used the OraSure rapid test. It takes about 20 minutes. At the time, whenever we were trying to learn how to do this, we found that not every, but a lot of nonprofits and even our Department of Health and the people that we were appealing to mentor us and teach us were just exactly like we are now, and that is underfunded and strapped for time, and we had a hard time engaging with people to teach us. One great resource we found was at the Colorado Department of Public Health. They offer a free rapid testing and counseling class. It's like 15 or 20 hours, 3 or 4 days. You go all day, and it's absolutely wonderful. I went, and I think there was 25 people there. I was the only one representing hepatitis C, which is pretty typical. I think a lot of the HIV organizations also offer Hep C, but we've seen that a lot of times if it's an AIDS organization, Hep C gets put on the back burner, or perhaps there's not as much funding for Hep C. And so I've actually talked to the Colorado Department of Public Health in hopes that they will give more, because sometimes they have a waiting list and they have to turn people away, to give more positions to people that want to learn about hepatitis C. And so the counseling component of what we learned was absolutely wonderful. We role played all kinds of far out situations with, the worst case scenarios. We tested one another, and that was extremely helpful. And maybe that's something I've talked to Ray at OraSure or even NASDAQ may be able to coordinate, is some sort of training for the actual rapid test. I think that would be really helpful. It was a huge help to me. So we decided whenever we wanted to test that we wanted to go to where we could reach the most people who were vulnerable, the most people that were at risk, and we considered everything. And I have a list of people that we serve, and you know, the CDC put out a county level vulnerability report a couple years ago, and I forwarded it to Alyssa if anybody's interested, and I know many of you have seen it, but it actually shows us where HIV and HCV are most prevalent. And it absolutely coincides with even some reports that have come out in the last few months where overdoses are taking place. So these are pretty reliable, and you can see they're kind of clustered up around Tennessee, West Virginia, Kentucky, that area. Next slide. So this is the makeshift lab counseling area. Alyssa, are you still with me?
I am, yeah, and we're on the same slide as you, so you're all set.
Wait. Thank you. I think you're just following me because I'm okay. So I'm speaking really fast because y'all forgive me for that snafu on the mute, and so I want to get it all in. This makeshift lab counseling area, you know, ideally we have 2 or 3 tables where we can give literature, and then we also test, and then another area where we can give results. And we've learned over the years, you know, it used to be that we would only have clients who were positive sit down with us, but then we understood that, you know, people can see that and see that, you know, it's just certain people that we're having sitting down. And so everybody sits down, which is a great opportunity for us to share information. And we don't consider that our clients are just a one-off kind of come get tested and leave. Rather, we consider that perhaps this person could be a potential advocate in the community, and we call them mini advocates. So we try to give enough information that they can go share that with their relatives and friends and communities. And, you know, it's one thing that I would say that probably our biggest weakness is that we don't just have a harm reductionist going with us everywhere that we go. We tell our clients what we can in that short amount of time. There's a lot of misinformation. I'm sure y'all have heard about people who think they give the virus to themselves and all kinds of things. But, you know, I feel like we've made an impact just by telling people, you know, this virus is so small, it can live for up to 6 weeks. At the tip of a needle is the prime place for it to fester and live and thrive. And, you know, people are surprised when we share this information. So it's information that they don't have. And even if you rinse out a glass, that's not good enough. The virus is too hardy and small. You really have to go the extra mile to be, you know, to make things, to reduce harm. And so we share what we can, and we give our clients as much privacy as we can and as little judgment. And, you know, people perceive and can feel your heart, and they know when you're sincere. And so we just really make a point to let people know that we are there for them, and that everything that they share is completely private, and that we want to help and love them and serve them generously. And I think that goes a long way. So that picture that I have, the makeshift lab counseling areas, that was a couple. You know, they came at different times and they had a brand new baby. Both of them were positive. Both of them were completely shocked, but both of them were also extremely, I felt like they were wise and funny and worthy of life. And they happened to be at a clinic to get their teeth fixed. And so, you know, we were able to kind of compel them to come. We're pretty obnoxious about getting people to come to our table and get tested. And it may be that test, that screening that we gave them is the thing that propels them to get treatment rather than waiting 40 years until they have a symptom or a sign. Because as everybody knows, by the time you have signs or symptoms, it's oftentimes, you know, means you have cirrhosis or cancer. So the advantages of CBO testing is just people are paranoid about the government. So the public health department is great. We are not restricted with our funds. We have less paperwork and bureaucracy because we are not the government. We're passionate. We can show up when we want to and leave when we want to. And also we can overcome a lot of obstacles that health departments can't, because we go into rural areas where perhaps even transportation, money, those kinds of things are a problem for people. And so we, you know, county health departments are wonderful for people who have transportation or whatever, but sometimes these rural areas are really left neglected. So that's a big plus for us. We serve veterans. That's the next slide, Alyssa. And then the next one is a makeshift clinic, just more pictures. I will say that when we go to a health event, we stand up at our table. We don't use chairs unless we're testing or counseling. And we're really pretty serious about being available and ready and letting people know that we want them to come to our table. We use the spin the wheel, we give away gifts, whatever we can do to compel people to come. The next slide is of my family. When we decided to do this, we committed that we would not do it unless we could do it together as a family. So my whole family is on board. I did have one son who tested positive. I did not find out until a year and a half later that he had cleared the virus. That's pretty typical story, you know, just one of those stories that shouldn't have happened. It was it's an easy confirmatory test. My son didn't get it. And this was during interferon years, and there was really nothing approved for children. So we went for over a year. I did, thinking I had transmitted this potentially, life-threatening disease to my son. That's another reason. That's another reason that we do what we do, because we've had some of those scary experiences. The next slide is one of the clinics that we served in Tennessee. And so depending on where we go, we try to cater our information to that area. For instance, in Tennessee, there's a public health advisory out, and so we give every single person that comes through the clinics just it's a half sheet of paper of the public health advisory from the state of Tennessee, as well as on the back it has a map of Tennessee that kind of shows where the hot spots are. We share information with people. We've been able to talk to 16,000 people just at our clinics last year, passing out literature, testing, and we always get clients or people who call us after the clinic because they were too embarrassed or ashamed to come over and get tested during a clinic. And we're consistently engaging through social media. I think we have about 20,000 followers, and so we're just trying to spread the word however we can. The next slide is a slide of people who are uninsured or underinsured in rural areas. And we know, one lady came, she took a cab, came in a cab to get her teeth fixed, slept on the concrete parking lot because it's first come, first serve, because coming and sleeping on the parking lot was less painful than the abscessed tooth in her mouth. And so these people are desperate for health services, even if they have insurance. A lot of times they won't have dental or anything extra. Next slide is a POW Well that we tested at. So we're always looking for opportunities to test. I will tell you that at this POW Well we had 0 positives. I feel like even though it's one of the highest hit areas for hepatitis C, the demographic of clients that we pulled from the crowd were older mothers, and it just goes to show you the stigma involved. The people that have been using are more inclined to be at a higher risk, are not always going to come over to your table and get tested. And I know I don't have much time. I'm going to wrap it up, but just real quick, let's go to Help for Hep. One of my absolute favorite resources. They have over 100,000 resources for anybody with hepatitis C. It's helpforhep.org or .com, and I refer my clients there, so they put a zip code in. Everybody that works there, all the telephone counselors are clients, so it's peer-to-peer. It's not a medical advisory kind of hotline, rather a resource and an encouragement hotline, and I know a lot of people that work there personally, and they're wonderful. And then I want to just go down to link to labs. That's Wayne Goss B. He is amazing and underfunded, and yet he can provide labs and this was a huge problem of ours for a long time. I'd say the biggest problem, we could usually find a provider to link our clients to, but to get those labs, even to follow up and get an RNA to determine that you have an SVR was up to, $600-800. Wayne can offer these labs for $50, $100. He makes almost nothing, which is, because of his heart and desire to serve the community. So I really hope that we can bolster his business by using his resources linked to labs. Everybody keep that in mind. I'm sure many of you have heard of it. We've worked with the Surgeon General, and my last slide is just about people who inject drugs and the new cases that we see every day. it's our heart to really engage that community. And of course, we need more help in that regard. And I appreciate y'all listening.
Thank you so much, Carlene. And I apologize for the technical difficulty and that I had aimed for like 20 minutes for questions and we actually only have 5. So I apologize in advance and just want to kind of do a power round of questions, taking some questions we received. But Carlene, do you have like one piece of advice about your experience having been cured of hepatitis C and how that helps support the work that you're doing around testing? Because I think one thing that comes up is how to meaningfully engage communities who are impacted, and you're a great example about how you've taken your experience and used it to be an advocate and help so many other people. But just anything about that, having that experience involved in testing events.
I mentioned that I did not test, or I did not share my past for years and years because I didn't want to do so and kind of glory in those wild days. And I had a lot of children too. And so I didn't share for a long time. And then even after we started testing, I wanted to carefully consider how to share in a way that was wise and helpful rather than just coming in and saying, you know, I was an IV drug user. Sometimes that's not the thing to say. And so I do try to consider when and how to share my past. I'm always happy to do so if I feel like it can be helpful, and yet I feel like I need to be careful and strategically share information only when it's helpful because it's a sensitive subject, and it's still sensitive and hard for me to talk about. So it's not something that, you know, I necessarily love to share, although, you know, I've gotten a lot of, support when I have shared. But I do feel like I have helped people and broken down walls, and I've seen people be apprehensive and nervous at my table, and I just got the impression that maybe they wanted to tell me something, and so I have offered information, and sure enough, it would open a door for them to share with me. So I do share when I can, but only when it's helpful, and it is helpful at times, definitely, to share your own experience.
Great, thanks so much, Carlene. And since we just have a couple more minutes, another question that came into the chat box was for Christine, and it's a similar theme, but how does HBIGC recruit and hire staff from communities they serve? And this really speaks to this piece about meaningfully engaging communities and making sure we're holistic and inclusive. So do you want to do like a 1-minuter on that, Christine?
Yeah, sure, absolutely. So as far as for the communities that we serve, we definitely have a lot of volunteers that assist us in the education and the screening events, whether they are assisting people filling out forms or they are physicians in the communities that are able to provide testing. That's kind of how we are able to engage with people from the communities. As far as for our staff have been recruited based on their strategic qualities, whether it's they have language skills. So we've looked for those who speak Vietnamese or Chinese, or myself as a French speaker, those who are able to have certain public health skills. So that's kind of how we've dealt with the staff. But because we do volunteer, we do include a lot of volunteers from the communities and community leaders, we have been able to keep that bridge between our organization and the communities we serve.
Great, thank you so much, Christine and Carlene. And it's hard to believe, but it's just about 4. So I think we'll wrap it up here, but just want to thank you so much for joining us today, to our speakers and everyone who was on the call. And again, apologize that we had technical difficulties and didn't get to all the questions. There were a couple of questions that came in, particularly around accessing tests for those who are uninsured. And so I'll put together a little information and follow it up so we don't leave that unanswered, because I think that's a really important issue as we look at access. So thank you again for joining us, and I really hope you can join us in the future for our upcoming hepatitis testing partnership webinars. And as I mentioned in the beginning, please just let us know what topics you would like to hear and learn more about, or if there's any work that you want to present on and share out with this group. I think that would be a great space. So thank you so much, and I hope everyone has a wonderful day. And